I know earlier, and this isn't in your packets, so I apologize, but we are going to be electronically sending you by end of today these slides. So all this material you will have at your fingertips. But somebody did ask, and I didn't include it just because I didn't know the route we were taking, but I do think it's important, given the audience and given the terminology, and just to learn, just to understand context and how we're separating SBIRT out of the disorder realm, if you will, of substance use disorders, and how SBIRT is really a unique tool to engage in an early intervention versus clinical therapy. So I wanted to make that distinction. And so just so we're on the same sheet of music, the definition of disorder, so we refer to substance use disorders, and that's the current term that's used in the field. And the definition of disorder is here, and all of you probably know it by heart. You mantra it. And it's the clinically significant impairment or distress that exerts itself on someone, and then it manifests through behavior change, psychological issues, physical issues that really impair someone's ability to function, go to work. It affects their sleep patterns, their relationships, and it also interacts significantly with other morbidity, and it could even lead to mortality and suffering. So there's a definition there that we use, and each of the disorders are measured by clinical symptoms or clinical criteria, right, that have changed and over time through the iterations of the DSM. And so the DSM-5 that we're currently using, I just wanted to bring us all up to speed with the same sheet of music that we talked about earlier, where we used to have the DSM-4 where they had categories of abuse and dependence, and we now have, we've shifted away from these two terms, or categories, if you will, into understanding substance use disorders falling along one dimension that is broken up into levels of severity, right? Basically, how many symptom criteria you have, and if you have 2 to 3 of these, any of these, you're mild substance use disorder. If you have 3 to 4 to 5, you have a moderate substance use disorder. And if you have 6 or more, it would be categorized as a severe substance use disorder. And as we said earlier, the research and the team that developed the DSM-5 and the iteration and the changes to substance use disorders went through a series of modeling where they looked at the symptoms and the criteria, and they said, well, where's their fit and where's their not fit? And as we're making this change, should we be adding any criteria? Should we be removing any criteria? And as we discussed earlier, legal was dropped because of poor fit, and craving was added. And here's just the statistical table that shows that. So legal problems, if you're mindful of correlations and how the items all correlate with each other, 1.0 is a perfect correlation. So 0.8 and 0.9s are really highly correlated for all of the different substances. Legal problems you see there is a bad fit, 0.5, 0.3, 0.5. Just a poor fit, generally speaking, with all of these other criteria, which makes sense because these criteria are impairment criteria, right? Related to not being able to stop, physical, physiological, negative roles, social, interpersonal, and then craving actually was a very strong fit. So there's the changes of how the DSM-4 nuanced to the DSM-5. The other change was, or significant change, was moving away from a one-size-fits-all model. It's no longer substance abuse and dependence generally, regardless of what substance you're presenting with. They've now isolated it into the various different types of disorders. So for example, so you can have, there's 10 distinct substance use disorders. So if somebody was using alcohol, they would be assessed for having an alcohol substance use disorder. And then the DSM-5 has the 11 criteria, but each nuanced with maybe specific symptoms that might be a little bit different. And where you're going to see the difference is with the physiological tolerance or withdrawal, right? Because different substances like alcohol or opioids are more associated with physical withdrawal, and the stimulants, methamphetamine, cocaine, are more associated with the psychological withdrawal. So you'll see some nuances there, but very minor. So I just wanted to cover that, and then how we're going to then distinguish. Not everybody who uses substances will meet the criteria, right? They might meet one criteria, maybe, or none at all. And typically these are individuals, these are the adolescents, right? Usually adults who have been using substances and have substance use unhealthy patterns might fit into these criteria, but they might have a mild substance use disorder. So even within the clinical realm, how do we deal with a mild substance use disorder versus a moderate substance use disorder versus a severe, right? Really changing our practices to really shift towards individual differences or individual level care or patient-centeredness. This is different in the realm of like, you just don't do group therapy and treat them all the same way. And with substance abuse and dependence, that shifted us towards that model. Well, we just give them group therapy, right? And again, with this expansion and the healthcare benefits, one of the benefit that got opened up was individual-based treatment within the system that wasn't readily available under a substance use package, right? So that's now available, and it's important because there is a lot of individual differences. We see with the new diagnostics of it ranging from mild, moderate, and severe, and really being fluid. And do we move somebody from severe to moderate, and from moderate to mild? And what does that look like in terms of recovery and the processes that we're engaging in? The other thing to keep in mind is that in addition to the substance use disorders are really made up of these criteria, but they engage or they're interacting with a complex array of risk factors, right? So just because Susan, her substance use is related to these factors doesn't mean John is going to have the same factors, right? So really being mindful, and this is what helps when we're doing our assessment or something like the screening process, when we're being able to open-endedly ask them, we're going to get a variety of different answers than check this box and check this box, right? It's just this assessment that they go through the drill and kind of treats them all the same way. So shifting away and using tools or motivation-based interviewing practices is helpful to kind of uncover a lot of the nuances that are related to substance use disorders and the complexities. This whole substance use disorders is complex with understanding risk factors and what puts somebody at risk. So that's a whole other conversation that we can get into. But then there's this nuance now that SBIRT is adding to the field with respect to distinguishing itself from assessment, right? So we just went over the DSM-5. It's an assessment. It's a lengthy assessment, right? So how does the screening tool fit in, or what does SBIRT fit in? SBIRT fits in to identify risk, right? Not disorders. It doesn't go, you're not going to diagnose anybody using SBIRT tool, right? You're going to simply identify the risk of somebody developing, progressing, or having a substance use disorder. Risk for substance use disorder that you would then refer out for further assessment. So it's important to nuance it. When you're starting to do SBIRT, you're not doing assessments. Although the Department of Mental Health does you can bill for the craft under an assessment code, but there's screening codes for it as well. So just know that nuance. The literature does show us, though, that, and the way the tools were developed that Sherry's going to cover, is their risk, just like substance use disorders, falls along a spectrum of severity from mild, moderate, and severe. Somebody's risk, it also varies, right? Somebody might be at higher risk for developing a substance use disorder versus lower risk. And so we talked about that when we opened it up in the triangle, right? There's these different consumption questions, what somebody's using, the different type of substance, how often they're using it, how long they've been using substances, is going to categorize somebody at these various risk levels that the screening tool Sherry's going to cover captures, right? And so research in our field has done a wave of research, particularly with just general population, and has categorized them into these various levels, where there's mild risk, where they can decrease or discontinue their use just by simply maturing out. It's not really a problem. They're not going to benefit from treatment. If we put them in a treatment program, we'd be over-treating them. Moderate, these are usually early users that are at increased risk, and they could really benefit from risk reduction or interventions, not clinical therapies, right? And then the high risk or the severe, these are those that would then have a variety of other issues going on, and comorbidities like trauma and emotional distress and identity issues that we tend to see are at higher risk, right? So these are the risk factors that we tend to see with somebody that is going to have a substance use issue. So what I'm going to do now is I'm going to turn it over to Sherry, who's going to be talking about the screening tools of how we're able to identify risk and at what level of risk, given that there's 3 different categories of risk. And the screening tool she's going to cover allows us to do that.
Perfect. Thank you, Rachel. Good afternoon and welcome. So as Rachel mentioned, this is really about identifying sort of risk on this continuum. And as you've heard already, historically in our field, we've focused a lot of time and resources on prevention on one end or on treatment for people who have more severe issues on the other end. And we often miss this whole group in the middle that is at risk and is engaging in behaviors that place them at risk for developing future problems. But at this point, an early intervention may be enough to actually kind of curb or change behavior. When I think of SBIRT, I think that there's it's an engagement tool, but there's also a pretty specific place and time for SBIRT. And given that the work that you guys do, and I'm going to ask you in a minute just to kind of a few of you to share your workplace settings so I have a better idea. But SBIRT, the biggest barrier to SBIRT implementation, we know it works, okay? But when it doesn't work, it's because there are barriers to implementing it. Who's going to do the screening? Who does the brief intervention? How do referrals get made when referrals are necessary? Is there an increased workload for some people? Who uses the screening tool and which screening tool do you use? Are you in a setting where you're really more healthcare focused, or are you really counseling focused, or you do a lot of behavioral health, or there's a lot of mental health and substance use in your setting? Or are you in a setting with older adults or with adolescents? So there's a range of settings that SBIRT can be used in. And if you're not using the right screening tool and the right staffing fit, it can actually feel like it's not being that helpful to you as a team. And a lot of times there is not a one-size-fits-all. SBIRT should be thought of as being very flexible. And it also shouldn't be overthunk, okay? It is a pretty limited tool in that there's an enormous amount of flexibility. It doesn't always look the same in any place that it's done. So in some settings, we've seen it implemented in one way, and another setting it's implemented in another way, and that's okay. It is meant to be flexible and engaging and to be helpful to the providers and to the patients. And so nuancing it is okay. It was never kind of intended to be something that has to be done in a kind of formulaic way in the same way every place it's done. When I said don't overthink it, it's because I think the field that you guys are in, you have so many skills that the possibility of expanding something like SBIRT into a much bigger, into kind of more your realm of therapeutic work is pretty easy to do. But SBIRT in and of itself can be done by everybody from peers to medical assistants to nurses to physicians to therapists and counselors. But it is a very narrowly focused motivational interviewing session. That's what SBIRT boils down to, is that it is a very targeted MI session. It is, the platform is MI, so if you're comfortable with MI and you know MI, the possibility of expanding it into kind of other areas is great because people kind of want to do more than actually what needs to be done. And depending on your setting, you may be in the situation where you can have multiple sessions with a patient, or your sessions of brief intervention can be longer. But in some settings, in hospital settings or in some clinical settings, you may have 15 minutes with a patient in the type of job role you have, and that's okay. The idea is that intervening early and often with people who are at risk is going to benefit them. And it's okay if it comes from someone with sophisticated skills, or sometimes we can train people that really are not in the area of mental health at all, but they can follow some pretty specific steps and still have an impact. And the reason why is because we have to think of SBIRT as this is a seed planting opportunity. That's what it is. Some people are going to have behavioral change following your brief intervention, and sometimes they're stewing on it for a long time, and it requires kind of repeated seed planting opportunities. So when you think about what a positive outcome is of a brief intervention, if you are familiar with motivational interviewing and a sort of stages of change model, if you've gotten a patient who's in pre-contemplation to have the tiniest aha moment, and if they've sat in contemplation for a few minutes and said, I wonder if, that's a win for SBIRT. If you have someone who's in contemplation and for a little bit of time, they've thought, I think I could take some action, and they're kind of preparing to and thinking more about it, that's a win. Because the idea of a brief intervention is, your job is there are people that do the work you do and at your settings that it is their job to do more in-depth and long-term work. But in terms of what the definition of SBIRT is, it's really your job is to, boom, plant a seed and get out, because probably in many occupations, you only have a limited time with the patient. So you do the most you can in the time that you have. When I think of where SBIRT grew out of was in healthcare. And it actually grew out of settings when you don't have a ton of time with the patient, but you want to have as big of impact as you can. And it grew out of work where you are potentially capturing a patient in a teachable moment, where you have someone who just got busted for a DUI, showed up in the emergency room with an injury that's linked to alcohol, or got a DUI linked to alcohol, went to their primary care doctor, got some lab results back that were not favorable, bam, linked to some increased use of a substance. Those are those moments where we want to jump on it and take the opportunity to kind of plant a seed and think about behavior change and kind of as quickly as possible. So the parallel in healthcare is, in healthcare, we often think about, healthcare itself tends to be problem, solution. So we identify the problem. Your blood pressure is high. The solution is we can give you medicines, we can change your diet, we can change your exercise, we can do this. So we go from the problem to the solution. And that environment is kind of rapid, so you kind of don't spend a lot of time in the middle getting patient buy-in and understanding of what's really going on with the problem. Because we kind of expedite in the medical field. Right from the problem, let's move towards solutions, because we have some evidence-based solutions, so let's get to them. When it comes to behavioral health issues, whether it's smoking related, drinking related, or exercise related or eating related, we know that moving from problem to solution doesn't have as much impact if we do problem, spend a little bit of time engaging the patient around problem, and spend a little time with the patient developing patient-centered solutions. The likelihood of solution being accepted by the patient is much greater. So what a brief intervention is kind of moving from problem solution to problem, a little bit of counseling here with the patient, even 5, 10, 15 minutes, to try to develop solutions that are a good fit for the patient that they may actually make change around. So in a healthcare setting, this may look like, what's your name? Scott. Have you already been picked on, Scott, because you're in the front row? Okay, you don't mind. All right, so I'll make Scott. Scott comes in. He has his blood pressure is 120/80. He's sitting down in the chair. The nurse does his blood pressure. It's 120/80. Does anybody care? No. Nope. Nobody cares. Everybody's great. Good job, Scott, good job. It's gonna be written in his chart and everybody's moving on, nobody cares. Scott comes in and his body temperature is around 98.6 or 7 or 5, something in that area. Does anybody care? Nope, everybody thinks A-okay. Those are indicators, some sort of indicators of your health. But at some point, each of those basic sort of biometrics it goes from a green flag to maybe a yellow flag, and maybe even a red flag, okay? We need to think of our screening tools that we're gonna go over in a minute as those same very simple buckets. Is it a green flag, a yellow flag, or a red flag? And if it's a green flag, we're good. If it's a yellow flag, we need to kind of figure out a little bit more. We're gonna have some sort of intervention. If you're a yellow flag, what body temperature is gonna give me a yellow flag on him? 63, holy crap, that's a red flag, man. Okay, all right. Yeah, maybe 100, 101. When it starts getting above that, we're kind of in red flag territory where, there could be something, they're gonna wanna do more with the patient. There's more screening, there's more testing that's gonna be done to determine what might be wrong, what the issue is with the patient with that blood pressure, with that body temperature. Blood pressure, 140 over 90, it might still be kind of yellow flag, but it's starting to get up there. There's gonna be some level of what's going on, did you race here? Are you under pressure? Have you had high blood pressure before? Why don't you sit down? We're gonna redo it in a few minutes. Let's retest you. If it continues to be high, then we might talk about the what next steps. A conversation is typically had with a patient that raises a yellow flag for us, and it might go something like this, like, Scott, as your healthcare provider, I have some concerns because this screening test indicated that you have, 140 over 90. The nurse or a doctor may even say, high blood pressure can be associated with, stroke, or even low blood pressure can be associated with this, but whatever it is. High blood pressure can be associated with stroke, with, a heart attack, with an aneurysm. They might go over some of the health-related issues and say, as your provider, I'm a little worried, so can we talk about what's going on and maybe some, possible ways to reduce your blood pressure, okay? This is a brief intervention. You take this same intervention and you move it to substance use, and you think of the substance use screening tool as these screening instruments that tell us yellow bucket, green bucket, yellow bucket, red bucket. And if it's a red bucket, it tells me that this is probably a person who's definitely gonna need more assessment and definitely need a higher level of care than probably what we're doing here. That's often somebody who needs more intensive services and maybe kind of specialized substance use care, okay? People who are specialized in this. A lot of people fall into the yellow buckets, and a lot of times what they need is, what kind of lifestyle change stuff can we work on together to help you reduce your risk for those consequences that are down the line if this behavior continues or if these indicators continue at this level. This is our yellow bucket. The yellow bucket gives us an opportunity to do these brief interventions. Maybe it's 15 minutes. Maybe a doctor has 5 minutes in an emergency room. Maybe a nurse has 15 minutes while they wait for the doctor appointment. Or maybe in a counseling setting, you have 3 or 4 brief counseling sessions that are either paid for or that are recommended somehow. In the state of California, the reimbursement is that you would have 3 or 4 of these brief interventions that can last 15 to 30 minutes. And that's reimbursed in the state of California. So there is flexibility in how we think about what these brief interventions entail, but they all do the same thing, which is they involve a motivational interviewing platform, okay? That's the kind of the basis in which they all operate from. There's been research on, there's probably at least 7 or 8 different brief interventions in terms of different steps. So for example, the World Health Organization has a brief intervention that's like 6 steps. NIAAA, which is the National Institute on Alcohol and Alcoholism, they have one that's called the 5 A's. It's like ask, assist, appropriate advice or something. So they have the 5 A's. So it's 5 steps. Yale has one that's 4 steps, the brief negotiated interview, which we're using. There's one called flow, which is 3 steps. Rand uses a 5-step one also. There are different steps, but what it boils down to is they're really the same kind of steps. It's how finite you divide your steps, essentially. They all involve some level of engagement with the patient, giving them some feedback, doing a little bit of motivational interview, and wrapping it up and figuring out what the next steps are. And whether you divide that into 3 steps, 4 steps, 5 steps, or 7 steps. The research shows that the specific brief intervention, when we compare them against each other, really doesn't matter. What matters is that something gets done over nothing. So any brief intervention is better than no brief intervention. Now because there's these core components or critical steps that need to get done in each one of these that is gonna make the difference. And as long as you are doing any kind of evidence-based brief intervention, good for you. It's better than doing nothing. We're gonna teach you a 4-step one today. If you've already been trained on brief intervention and you're doing something that you like because the steps are simpler or easier for you to remember, totally fine. Doesn't matter to us. The most important thing is that doing something is better than nothing. And what we've done is kind of provide this card right here has our 4 steps. This is the Yale Medical School's brief negotiated interview, has these 4 steps. Raise the subject, provide feedback, enhance motivation, negotiated plan, and pretty clear definitions of what each one of these. There's one that actually combines raise the subject and provide feedback together. That's a 3-step one, but they do the same things, okay? So it's kind of more important that you learn the core components of them. I'm gonna go over the screening tools, and in the settings that you guys are in, I think, thinking through the screening tool, do you already use something to screen? And there's one thing I would say is you may be using something already to screen. Maybe you already ask a few questions to screen, which is great. One of the big benefits, though, of using a standardized screening tool, we've provided in here the audit, and there's part of it is the audit C, the DAST, there's a CRAFT, and there's the S2BI. The CRAFT and S2BI are adolescent, the audit and the DAST are for alcohol and drugs, and they're more adult-focused. Using an evidence-based screening tool is important for, I would say, one main reason, is that a validated screening tool gives you cutoffs. So I know that 98.6 means something. I know that 120/80 means something. When you get familiar with these tools, you're gonna know that a 2 on a CRAFT triggers the next step. You're gonna know that at the S2BI, people get in these buckets, and it tells you specifically what number, the score on these are the equivalent of your lab results, if you will, in the sense that we know that these numbers mean something, they tell you what to do next. This is helpful for one main reason, is that this is it makes your job objective. When you're giving patient feedback during the brief intervention, and you have the ability to talk about something, a tool or an instrument in an objective way, the same way that your medical provider says, your body temperature is 103, and that's a little hot, that's scary, okay? 104 is getting up there. Your blood pressure is 160/100, I'm worried, okay? It gives us the ability to provide feedback to the patient that we all are on a common platform. Some counseling settings and other settings use their own, like, have you used alcohol or drugs, and what have you used? That is good that you're starting the screening process, but none of us really know what the trigger point is in that. We don't know, it doesn't give us direction as a provider. For many of you who are clinically trained, it might be okay because you are savvy enough and you kind of figure out with your patients who's at risk and who's not. But in a lot of settings where SBIRT is done and done successfully, a nurse cannot rely on, I wonder, are they a yellow bucket or a red bucket? They gotta know. They gotta be able to make some decisions quickly about this. So this is why using objective tools that tell us is a much better choice. And if there's a number of screening tools out there, if you're in a setting that reimburses for brief intervention, which a lot of settings do in the state of California, you're gonna have to pick a tool that is evidence-based already, and they have a list of them, and that includes the audit, which we have here. So the audit has 10 items, And we've kind of tried to make your job a little easier in terms of how to determine kind of what buckets people fall into when they ask these questions, when they're answering these questions. But the audit is a 10-item screening tool. The DAST is also 10 items, and it screens for drug use only. And then the CRAFT, and we have the S2BI for you. These are adolescent specific. If you're working with other populations, there's one for pregnant women, there's different tools for older adults, there's a number of different screening tools out there. So a portion of, I'm gonna walk through, what I wanna do is have people ask these questions out loud. It's a Likert scale, it's from 0 to 4, where 0 is really not risky and 4 is at the most severe risk. But I'll start and then maybe we can just go around and you can say these questions out loud, these 10. How often do you have a drink containing alcohol? Never, monthly or less, 2 to 4 times a month, 2 to 3 times a week, or 4 or more times in a week. Question number 2.
How many drinks containing alcohol do you have on a typical day when you are drinking? 1 or 2, 3 or 4, 5 or 6, 7 to 9, or 10 or more?
How often do you have 5 or more drinks on one occasion? Never, less than monthly, monthly, weekly, daily, or almost daily?
These 3 questions actually form what's called the audit C. Now, on your card right here, we have the scores for the full audit. The full audit is 10 questions. What research has shown is that those first 3 questions are predictive for about like 70% of the total instrument. So you get some benefit by adding the remaining 7 questions, but the benefit is modest enough that what the state of California, but also researchers say is, depending on your setting, you don't have to do the full audit. You may be in a setting where you already ask a number of questions, and adding 10 questions is just too much. If you can add 3, those are the 3 that you add, and they're scored separately. They've got a validated score that we'll go over.
How often during the last year have you found that you were not able to stop drinking once you had started? Never, less than monthly, monthly, weekly, daily, or almost daily?
How often during the last year have you failed to do what was normally expected of you because of drinking? Never, less than monthly, monthly, weekly, daily, or almost daily?
How often during the last year have you needed a first drink in the morning to get yourself going after a heavy drinking session? Never, less than monthly, monthly, weekly, daily, or almost daily.
How often during the last year have you had feelings of guilt or remorse after drinking? Never, less than monthly, monthly, weekly, daily, or almost daily.
How often during the last year have you been unable to remember what happened the night before because of your drinking? Never, less than monthly, monthly, weekly, daily, or almost daily.
Have you or someone else been injured because of your drinking? No, yes, but not in the last year. Yes, during the last year.
Number 10, has a relative, friend, doctor, or other healthcare worker been concerned about your drinking or suggested you cut down? No, yes, but not in the last year. Yes, during the last year.
Great, thank you. So this instrument, this one's a little hard to see, but as you can see, we went through and scored for you just for fun to see how someone would do. So let's add this up. This is 0, 1, 2, 3, 4. So this person got 3. Count it with me. 4, 5, 6, 7, okay? So the audit score is a 7. The audit C score is a 3 plus 1 is 4. So on our card here, if you look on the bottom of your audit, it says, what's a 7? Yeah, 0 to 7 is zone 1. It says alcohol education. It's pretty much no risk. It's getting closer to the low risk, but however they answered here that they have drinks, they have 2 to 3 drinks a week, and when they do drink, they might drink 3 to 4 drinks, and the rest is, it happens less than monthly. It's very infrequent. Now, according to the audit C, this would be someone who's at relatively low risk. So this might be just someone that you kind of remind or that you have a conversation with that like, that the amount that they're drinking now, if they sort of started to notice increases, that they would probably fall into a low risk category and probably would want to consider where they're at now or less, okay? And we'll kind of talk about what some there are guidelines about the amounts of alcohol. One of the things I would say is the audit C, the trigger point for the audit C is really a 4. Okay, so this person scored a 4. A 4 on the audit C says that that's really almost in the next zone of at least ask a couple more questions. Now, this person says they drink, let me see, what does it say? 2 to 3 times a week, and they drink 3 or 4 drinks every time they drink. Why might those questions, is there anything in there that seems like a potential yellow flag? I mean, this person's scoring really in the no risk category, but at the top, getting into kind of some risk. Anything about that that would make you curious at all? 2 to 3 times a week, 3 or 4 drinks each time. Yeah, 3 to 4 drinks. And one thing we know is people do sometimes minimize. And as we'll see in a minute, people often aren't that aware of what 3 to 4 drinks. 3 to 4 standard drinks is, some people are not totally aware of what that is. They might be like, well, it's like 3 to 4. That's probably like, and then if you really dug deeper, you'd find out that it's like a bottle of wine, which is probably more like 7 drinks or 6 drinks. Sometimes people minimize or they're not fully aware of what a standard drink is. So when someone's getting like at a 4 on the audit C, there is a little bit of, ask a couple more questions just to make sure that they understand and we understand. We have a shared agreement of how often and how much each time. Okay.
The other thing to note, and I brought this up earlier, is that these questions on these validated forms, they've done research and they crosswalk or map onto the DSM categories that take into consideration consumption, severity, consequences, that then the scoring algorithms is based on that, and that these are objective indicators that we know we should be mindful of.
Another thing I want to mention is the instrument actually says that for women, a 3 or a 4 is definitely something that we should be asking them about, because women's consumption is different than men. The recommended daily maximum for women and the weekly maximum for women is about half of what it is for men. And when I say recommended, it's not you should drink this much, it's do not drink more than this. Here's our at or low risk amounts for men and women. For women, 7 drinks a week is really your maximum. That's about 1 per day. Sometimes people will drink more than that, but what it's saying is on average, your weekly total should not exceed 7 drinks in a week. And in any one setting, it should not exceed 3 drinks, because beyond that is a binge. These guidelines are set through research that shows that when people on a regular basis start exceeding these amounts of alcohol, that their physical health and their mental health outcomes start progressively getting worse, directly related to the alcohol. So depression, alcohol-driven depression, or anxiety goes up, or sleep issues start to go up related to alcohol. Physical health consequences start to go up related to alcohol. So these guidelines are, when you think of SBIRT, what we're really talking about is a harm reduction interaction with them and how to ensure that they consider lessening the amounts of alcohol they're currently using. Some people may decide they don't want to drink at all, but for many people, it's really about, can you get yourself below these guidelines, okay? And I'll add one other thing. These guidelines are based on otherwise healthy adults. These are people who are healthy. If you're in counseling settings and you're seeing people who have, mental health issues and they're on psychiatric meds, this may be way too much for them. There may be other issues going on. So these guidelines is the federal government saying in otherwise healthy adults, if you start to exceed these amounts without any other physical health and any other mental health conditions, these are your maximums. And women metabolize alcohol differently. You've heard the saying, she can drink like a man. A woman who drinks like a man is gonna be sicker than a man who drinks like a man on every level. Women physiologically cannot sustain the amount of alcohol to drink like a man, okay? So when you see women who have high volumes of alcohol, they also often have high levels of co-occurring medical and mental health issues. And it is ways we metabolize alcohol. It's differences in our body fat percent. We have different amounts of enzymes that break down alcohol. So, and the same for older adults, which we don't have on here, I don't think, but as people age, they also start to have more difficulties around alcohol. So some people will feel like they've had a kind of basic level of alcohol consumption their whole life, and yet as they age, the consequences for that same amount of alcohol intake start to get progressively worse for you as you age. Which is hard to hear. It's hard to tell older adults who've been drinking like, you know, their 2 highballs each night and they say, I've been doing this my whole life. But now it could potentially start medically complicating and mental health issues much greater degree. We also talk about standard drinking units because it is important during the screening process that people are clear. This is why screening tools are good, but clinical judgment is also important, is because somebody will say, I only have 1 drink a day. But if they're drinking what Alan and Roger are drinking, we need to kind of be a little discerning with them if we're seeing other clinical indicators, or if we can ask patients, like, well, tell me a little bit more about what you drink. And I often use the story of an older adult, older female who was being treated for mental health related issues and medical issues. And she was saying that she drinks a little bit. And so her screening tools were that she just had like a drink a night. But some of her family was concerned because she had like more memory and kind of dementia related stuff. So they had concerns about that. And when the clinician got more discerning about how much the 1 drink is and what kind of things she was drinking, she said that she liked vodka, she liked it really cold, she liked to, you know, put it in the freezer, and she said she had like a 1 good size drink each night. So it was like, well, what does the cup size look like, or whatever, the glass size look like? And her response was, well, you know the cups that you get at 7-Eleven. And from that point on, everything you hear is there's nothing at 7-Eleven that is not supersized, okay? Every single cup at 7-Eleven is beyond a standard of drink. It's either a big gulp, a double big gulp, a triple big gulp. They are all over the standard drinking units. So what was considered a standard drinking unit, it was determined that she was probably drinking about 5 to 7 drinks per night, because she would fill up, and she didn't use ice because she thought it watered it down, but she would put it in the freezer. So imagine how much she was drinking at night. So a lot of the memory and cognition and the slipping and sleep issues that her family was so concerned about, well, it was hard for them to determine how much of that was directly related to basically drinking herself into a stupor every night versus did she have real ongoing issues in this area. So a bottle of beer is pretty safe if it's a standard beer, a Budweiser, a Coors, a Miller, Pacifica, Corona. They all come in a bottle. That's 1 standard drinking unit. There are some more heavy kind of microbrews that maybe come in that size that are going to have disproportionately higher amounts of alcohol. 5 ounces of wine. Now, on average, when you go to a restaurant, they typically pour about 7 ounces, so they do over pour, not hugely. But if you go to a bar and you get a beer, I don't even know, I'm a beer drinker, Rachel's a beer drinker. I don't think I have ever seen a draft beer come in a mug like that anymore. The minimum is 16 ounces, and sometimes they have 22 ounces. So 2 beers, it's 2 standard drinking units, okay? Something like a margarita, we don't have margaritas up here. Margaritas are actually 2 to 3 standard drinking units, okay? A solo cup, so if you're not in something that's a contained amount that's packaged for you, a solo cup is typically about 18 ounces if you fill it up. So it's about a beer and a half. So when you have a couple of beers, you guys are probably all past keg age, I'm not sure, but if you're filling up your solo cup, you're probably getting about a beer and a half, which means 2 of those is about 3 standard drinking units. That's your max for a female. More than that starts to turn into what we call a binge drinking. Now, binge drinking it might have a connotation like, you know, you're swinging on chandeliers and jumping off balconies and doing silly stuff. But what a binge episode really means is the amount of kind of physiological damage that you start to do, because your body can only process so much alcohol in a given time period. So a binge is more damaging, okay? It's why we track it with college students and other areas where overconsumption is prized or valued. It really is more damaging for people. So we track it differently because it can have greater health consequences. When you pour your own wine, I always like this. I was leaving this is maybe like 2 or 3 years ago. I was doing a talk for the county of Napa. So I had to drive like 2 hours to the airport. I'm leaving wine country and I'm listening to NPR, and they were doing, a study had just come out on people and kind of standard drinking unit sizes. And I was like, oh my gosh, the timing of this. And then they started talking about when you pour your own wine at home, okay? They said people tend to overpour, about 8, 9 ounces. So they almost, most people have between 1.5 and 2 standard drinking units when they're pouring their own. So do you think people overpour white or red? Yeah, they overpour white. People tend to overpour white than they do red. And there's also a difference in your pouring, if you pour while your wine glass is sitting like this, or whether you pour it while you're holding your wine glass. Where do you overpour? Holding it. So if you are a white wine drinker and you're holding your wine glass, people, you are probably super overpouring. Okay, people tend to be more conservative when it's on the table, and when they're pouring red wine, they actually get closer to a standard drinking unit typically. And most bars pour about 7 ounces is kind of standard. So the other screening tool, we're gonna practice a couple screening tools right now and take a few minutes. The other screening tool that we have on there is the DAST. The DAST is a drug-specific screening tool. It's worth it to familiarize yourself with the questions, but I will say this, in the state of California, they have not, at this point, screening and brief intervention and referral to treatment is not reimbursed for drug use, only for alcohol use. Now, other states have not taken that approach. California was very conservative. They basically said, most of the data are for alcohol. We know that alcohol use, whether it's emergency room departments or primary care, that's primarily what we're going to be talking about. And so they kind of put their weight behind that. And there are more data to support the use of brief interventions for alcohol than there are other drugs, okay? Yes?
But I should say that what they found is it's typically just not alcohol. So it's usually they're smoking, or they're smoking marijuana, or using prescription drugs, or using other things. So they'll collect all that other information, but for billing purposes, it goes down as alcohol.
That's right.
But they still pick up the other substances.
Some people will choose to add an additional screening tool. While they're screening for alcohol, they're like, hey, let's just add other drugs, alcohol and other drugs while we're at it. But as Rachel said, the reimbursement is tied specifically to alcohol. There are a lot of data to support for alcohol, but that's because it's been researched longer. And not surprisingly, other than marijuana, a screening tool is like brief interventions are brief by definition. So when somebody screens on a DAST that they, have been, they've used heroin twice in the last week, we don't have recommended guidelines like we do for alcohol because it's a legal drug and it's very well researched. We don't have recommended guidelines that say, all right, so if you're only using heroin 2 times a week, it's not a binge and you're probably safe. Like, we don't have guidelines. So in the world of brief interventions, any drug use is risk, okay? So it's black or white. It's if you fall into that category, you're at risk. If someone says, well, I used crack twice in the last month, we say, boom, that's risk. Even if we don't try to gauge how much the risk is or something, it just automatically falls into risk. Whereas alcohol, we do kind of have these gradations because it's a legal drug.
We do, any use is risk, and what we don't have is like you saw in the video when Dr. Lehman says, well, do you think, can you reduce your use by 1 day? These kinds of things. With alcohol, that's a more comfortable conversation. With drug use, it's not comfortable. But we do have, if you look at the DAS, which is on the other side of your audit, it's the same kind of questions. It's based on the DSM. It's those questions that get at consumption patterns, the frequency, how much they're using, how long they've been using, and if it's related to any impairment. That crosswalks with the DSM. And if you see at the bottom of the DAS, you're going to have those categories of risk. So they have done validity studies where they do kind of map out low, moderate, high risk. So it's risk, and that puts on
Right.
our alarm, but there are levels of risk.
So you can even see on the DAST, if they even score a 1 or 2, it's low risk, but a low risk here is even some sort of brief intervention. So even answering kind of yes to any of them gets you some level of an intervention, even if it's not intense. Whereas for alcohol, you know, you get up to 7 points and you still get no risk. So what I think we're going to do now, there is the CRAFT tool as well. The CRAFT is specifically for adolescents. And you guys are you all in adolescent settings or mixed, adult, adolescent, both? The CRAFT and the S2BI are other good choices for you. If you're working with adolescents, you may already be using the CRAFT. If you're using the CRAFT, you know, I guess keep using the CRAFT. The S2BI is actually a really good instrument with science behind it. It's not as widespread used because it's newer, but it does actually give you a gradation, which is nice. It kind of places the buckets. It's got the green, yellow, and red buckets in a way that's easier for providers to kind of quickly assess what next steps should be, whereas the CRAFT is much more black and white. It's if you get 2 or more, we got to do something. That's the trigger point. Good.
Something to notice with the S2BI, and I don't think we have it here on the screen, is the S2BI, if you're on that sheet, the only thing, it's really quick and brief. There's literally one question, but it's about consumption. It's consumption of, did you use tobacco in the past 12 months? How often, right? Never, once or twice, monthly or weekly. And then it has 6 other substances that are frequently used among adolescents, including inhalants and the prescription drugs and the synthetics. And so that algorithm at the bottom, it uses the never, the once or twice, the monthly or the weekly to indicate the response, right? So if you go back to the CRAFT, these questions aren't about how often or how much, right? And so the S2BI, the screening to brief intervention is what it stands for. It recently came out as the validated tool to use that is a very objective measure of just use. How much to put them into these risk categories. Sort of what Sherry was talking about earlier, right? Your blood pressure, you're using, it's this level, flag for risk. If an adolescent reports they're using and this much, flags for risk. However, settings have said, well, we kind of still want to use the CRAFT. So they've incorporated both of them, because if you look at these questions, the CRAFT is an acronym. How many of you are familiar with the CRAFT? One person? Okay. The CRAFT is an acronym that stands for CAR, relax, alone, forget, family, friends, or trouble. These are indicators that usually coincide with an adolescent substance use, right? So number 6, have you ever gotten into trouble while using alcohol or drugs, right? This is a biggie. Trouble on the T. So settings want to use that. They want to use that question because adolescents, do they tell the truth? Sometimes. But if you're asking on the S2BI just about use, they can say no. So and they, a lot more times than not, say no. So these kinds of questions this has been validated and very useful for providers to get at their issues in another way by asking about getting in trouble. Or number 5, does your family or friends ever tell you things about your alcohol or drug use, like you should cut down or stop? Have you ever used while you were alone? Do you use to fit in and relax with your social setting? And then number 1 is really big for prevention efforts around, have you ever yourself or someone else drove in a car while you were high or using alcohol or drugs, right? So these questions are very useful in addition to the consumption to then also gauge and help them think about, usually during the brief intervention, like you saw the teenager, about what's the good things, what's the not so bad things. And if they don't bring those up with the resistant youth or the youth that doesn't talk a lot, because Brady talked a lot, you can come back to your screening instrument and say, well, let's see how you answered this. You said you got into trouble. Tell me about that, right? So you can use it as a barometer or as a way to help guide that conversation for young people who don't like to talk. And now in this era with technology, You could just sit and text each other probably. Text the question, they'll text back, right? So wanted to just mention that.
Like, how are you feeling now? And as Rachel mentioned on the craft, some of the things I like about the craft questions are, number 2 says, do you ever use alcohol or drugs to relax, feel better about yourself, or fit in? Kids might be using like for peer pressure, but once they're using it to change themselves, they're using it because they want to change how they feel. It tells us something. When they say that they have used alone, youth are like social creatures, and if they're using by themselves, not a good sign. Adults who drink by themselves, probably also not a great sign, because alcohol is very convivial and social, but sometimes people do and don't have problems with it. Adolescents or youth who are using by themselves, it's in and of itself, it kind of tells you something. And then the blacking out, do you ever forget things that you did? These are things that can be helpful in addition to the quantity and the duration questions that happen from the S2BI. So what I think we should do now is, if you can, we'd like you to pick one of these instruments and walk through it and actually go through the process of scoring it, just to kind of walk through. You can pick the audit, the DAST, you can pick the S2BI or the craft, and one of you can, we'll be using the score that you get on this, we'll use later for a practice of the brief intervention. So you can role play this. You don't actually have to play yourself if you're low risk. At the very least, we'd want it at a high enough level where there's going to be some intervention that's going to happen so that we can use your objective tool later. Okay? All right, so why don't we take about 10 minutes?
Yeah, and the other thing, the reason why we're emphasizing this is, as we talked about earlier, we're not familiar, so we're not going to talk about it. So just having us go through the questions and read them, we're familiar with them. So that practice in of itself, we've heard, has been really helpful for those of us that usually didn't get trained on alcohol and drug use.
The hope is that these instruments are designed in a way to make scoring kind of idiot-proof, in the sense that people are running around, they're totally busy, the last thing they want to do is be adding up a lot of numbers in their head. Now, I'll get to you in just a second, many electronic health records have already embedded these types of screening tools. So for example, the Department of Mental Health does have the Audit C embedded, and parts of the craft is also in, I think, the adolescent paperwork or the child paperwork at Department of Mental Health in LA County at least has the craft embedded. So some systems have already embedded these evidence-based tools, and other systems have even gone to the point where it scores it for you and a score pops up and gives you a flag, or at least it says, it kind of says you need to do something, or the score was a 7. Some of them have even another box that says, was a brief intervention completed? Because they're trying to ensure brief interventions don't always happen unless people are accountable for making it happen. Now that there is reimbursement, more people are doing it because you actually get paid to do the practice. But depending on how you're paid, you may not be getting paid for this. So if you get reimbursed in a bundled rate, it might be that you're expected to do all things and it's one packaged price. So you don't have to be billing for these separate items. So in any case, it's something to think through in terms of which instrument you use and how you use it. So the goal is for these things to be easily scored and for you then to have some indicators. So the score from this should be your 120 over 80. It's your 98.6. It tells you something that gives you some indication about where the kid, the youth, the patient, the client, the consumer, whatever, where they're at when it comes to substance use. And again, like all screening tools, they are screening tools. They don't replace good clinical judgment. They are not, instead of good clinical judgment, they are alongside good clinical judgment to kind of help you make some decisions about next steps around substance use. I just want to do a quick round robin of the places where you're working now. Is anybody doing some type of screening? Okay, so Rachel, I think are you guys doing screening at your site?
Yeah, we are. I work at Aurora Charter Oak Hospital in Covina. Our intake staff, they use the cage.
Got it.
Primarily.
Great.
And the audit.
They do both.
Yeah, they do.
And then they score it, and if the person scores a certain level, they do a brief intervention or they refer them.
It's in their chart in the admission records, and then the clinicians that see them next start in on that.
Good. So what you have is a pretty classic example. It sounds like the intake team does the screening, and then if something flags, then it's moved on to the next, like a...
They're primarily nurses.
Okay, primarily nurses will do a brief intervention or a referral to a higher level of care or start to work on referrals.
Right, and for those individuals who come in with the express desire to safely withdraw from mixed substances, they're put on a CWA, which is a detoxification protocol.
Okay.
But basically, the screening takes place early on, the first hour of intervention, and then various people follow up with it.
Good. So the example that you have, which I think is really important, is that in some settings, who does the screening, who does the brief intervention, and who does a referral to a higher level of care when needed can be 3 separate team players. In some cases, somebody does screening and then may do a brief intervention, and then they move it on to somebody else if there's a referral, somebody who knows more, has more knowledge about referrals. In some cases, it can be beginning to end can be the same person. It does not matter. What matters is that it fits into your geographic landscape of your office, or because getting it done is important, but how it gets done and who exactly does it is less important. But thinking through the procedures. Now, I'm curious, did you start working there, were you working there before it was done, or was an SBIRT kind of protocol in place by the time you started working there?
Well, I've been there for 32 years,
Oh,
so it's kind of hard for me to go back that far. I can't remember that far back, but we've always had some kind of screening device.
You have always done some type of screening and, okay, brief intervention, good. So what happens is when places start new, you guys now have integrated into people's job roles, and how screening gets done is kind of now it's probably integrated in there with other medical screening, and so it sounds like kind of a more seamless process. When people start a new SBIRT program, when they haven't done it before, there are things that get in the way. A lot of times it's the whoever typically does screening now it's kind of like it's an extra burden, like, oh, now I've got to be the one to do this. So you do have to frame it in a way that this is often a new job role for someone. So sometimes there's a champion that has to be identified at your site to kind of make sure that this actually happens. Sometimes whoever's doing the brief intervention, they're used to doing maybe more intensive counseling, and now all of a sudden it's like, well, I don't dig these 5-minute deals because I'm a therapist. I spend 50 minutes to an hour with my patients, and now I've got like this quick and dirty 10 minutes to try to plant a seed in this moment. So it can reshift what people's jobs are like, which is why it doesn't always get implemented. There's been a lot of studies on what gets in the way of implementation because we know it works, but until it becomes seamless like this, there was a study that was done like in Denmark where they introduced it in all these primary care settings, and they researched, the sites got funding to do SBIRT as part of research. After the research part was over and they weren't receiving funding, about half of the clinical sites still did it because they were like, well, it's kind of like what we do. It's part of, we think of this as kind of the broader perspective of health. We need to understand all aspects of health, including their drug and alcohol intake. The sites that didn't do it said, yeah, we like it, but it's extra work. And their model was a lot of the physicians were doing soup to nuts. They were doing everything. And so the physicians were like, I'm so busy, it tends to be like the last thing that I like want to do. And there was no kind of reimbursement to do extra work, so it felt extra. And so they did it when it was really bad and when someone was really severe and they needed really higher levels of care, but they kind of didn't routinely take people in this like risk category and try to do harm reduction interventions with them. So it is worth thinking through that implementation takes something. And so if you really are in your setting going to be doing something or supervising people who are doing it, you got to think about, is it the right screening tool? Have I properly convinced people that this is a good practice? Do I have top level buy-in? Do I have middle level buy-in? Do I have boots on the ground buy-in? Do I have buy-in at all levels for this? How is it going to happen? Whose job role is going to affect? Some of these things are important to think through in order to make it work.
What I'm going to do is I'm going to quickly walk us through some considerations when you're screening. And one of the considerations was knowing the standard drink and knowing the various kinds of standards around how much you can drink, and then really just being mindful of potential interactions with drinking and age and limits with females and males. But another thing to be mindful of is, and this is what I hear from students all the time and from colleagues, is, well, there's so many different types of drugs and the nuances of the various types of drugs and the short-term effects and the long-term effects and the whole gamut around that, which could be a little turn-off-ish to begin to go down that area and start asking about alcohol and drugs. And one thing that I think is important, and we tell this to our students, and I don't know if it's in your packets, I didn't see it there, but we will send you an electronic file of this, is to just be familiar with the commonly used substances and the various classifications, and starting at that point. So one way to orient you to that is the Drug Enforcement Agency. So if you go onto their website, you will see that there's different types of major substances of abuse that are classified into 3 basic categories. And there's depressants, and these are substances that slow down the central nervous system, right? They are referred to as downers, and when somebody ingests them, they will feel relaxed. There's also the classification of stimulants, and these type of substances speed up the central nervous system. And when somebody is using a stimulant, it excites the nervous system and they feel greater alertness and excitability, or wakeability, if you will. And then there's hallucinogens. Hallucinogens are referred to as psychedelics, and they cause or can cause euphoria with distorted perceptions of reality. They also tend to distort awareness or certain emotions, and it really is going to vary depending on the type of hallucinogen that's ingested. And so here is a table that provides you with a sense of the various substances and where they fall in terms of classification and their effects on the central nervous system. And some of the substances, as you notice here, can fall into different categories, like marijuana. I wanted to point that out. Marijuana can be categorized both as a depressant at low doses, or it can be classified as an hallucinogen at high doses. The same thing with MDMA or ecstasy or different club drugs. They can be both serve as a stimulant or a hallucinogen, right? Depending on the substance that's taken. And so it's important to understand, as you're beginning to talk about substances, know what they can do to the central nervous system and really link it to the central nervous system. Because we know from research, as I said earlier, that substances are a brain disease, right? And substance use disorders, not substances, substance use disorders are a brain disease. We have research that shows that has been conducted for decades using MRI and PET scanning, where they've taken pictures and slices of the brain of those that are healthy, non-substance users, and those that are substance users, from using 1 year to all the way up to 30 plus years, and seeing the changes that occur in the brain. And we do know that substance use disorders are adolescent onset. What does that mean? That means, from a developmental perspective, one of the hallmarks of development is sex, drugs, and rock and roll, right? Experimentation with alcohol and drugs is a developmental hallmark, right? Kids are curious, teens are curious. Access and availability of substances, we know, are very wide in our culture. And so we do know that the brain is under construction right? Until the age of 24. What does that mean? That the brain doesn't fully mature or develop, reach maturation until the age of 24. So youth, if we use the definition of the CDC, the Centers for Disease Control, youth are considered 24 years and younger, right? And so there's major processes that are developing here. Earlier, what's developing, it develops from the back and it prunes all the way to the front, right? And so here, what you notice is the last part of the brain to develop is the prefrontal cortex. And that controls things like motivation and judgment and emotions, right? These are the later things that are developing. Earlier, motor coordination, vision, sensations are developing, but this part of the brain is the last part to develop. And we do know that alcohol and drugs from studies, areas of the brain that are associated with the addiction process is the prefrontal cortex, right? Which is the last part of the brain to develop. So when you're using earlier and you're interrupting processes that are supposed to be normally functioning, developing. So it's interrupting some of those. So prefrontal cortex, why do you do what you do? When you ask a kid that, why do you do what you do? They don't know why they did what they did, right? It's the last part of our brains to fully develop. And so irrational decisions, impulsivity, and self-control, inability to control themselves is just a developmental issue. When you add substances to the mix, it creates even more issues and harm. The reward center, this is the addiction center of the brain, where dopamine and serotonin are released. And so drugs act on the receptors of dopamine where they, and other brain receptors like GABA and acetylcholine, but they all take place here, and it really affects the addiction process and the motivation and the desire and what just got added to the DSM-5, which is craving. And then the amygdala is the emotional part of the brain, which is heavily involved and associated with poor mood regulation and cognitive issues and stuff. The hippocampus is also in there next to that, but also gets affected by substance use. And so we do know, here are the studies that have, one of the studies that have shown over time what happens to an addicted brain. You begin to see that this is a healthy brain on the left-hand side, and more red is more dopamine and metabolic function. A healthy brain, you want a lot of dopamine and neurotransmission going on, not a lot, but normal, about 100 baseline level. And then the addicted brain has less of that, has less dopamine because it becomes changed. You start to see structural and functional changes occur. And the physiological neurotransmission of dopamine in a healthy brain becomes distorted and changed as drugs hijack that process because they work in that reward center, giving the brain more reward and more pleasure. And so over time, with continued use, we see change. And impaired receptivity, we also know that the memory or hippocampus is involved. So we see changes when cues and triggers are heavily built and set that will elicit in these things in the environment, people, places, and things will affect craving and memory of use, which is also associated with the addiction process and recovery. And then emotion regulation. We talked about that earlier, where substances take on the role of medication and feeling better and stress relief. And so studies support these brain differences. So we know addiction as a brain disease that is intricately involved, especially during development, in changing these systems that should be intact. So with youth, though, for those of you that work with young people, we know that the developing brain is occurring. So how these brains are adult brains that have been using substances for a long time, right? Years, chronic users. And we do know that studies have shown this, that the more severe your use is, the longer time you've been using, the more impairment or more disease, your brain is in a disease state. With adolescents, however, because like Sherry said, they have a shorter amount of time using typically, age of initiation varies. It could be as early as 12 or older, but sometimes it's later. 15, 16, 17. So they have less time use. We do know there's studies that are being done right now that are monitoring the impact of substances over time on these these core brain areas. But we do know from the studies that are available that there is impairment that is occurring with little use. So patterns vary, and we do know that's why we call it they're at risk population, because they might not yet have a substance use disorder, but they're at risk for developing a substance use disorder. And I say that because SBIRT in particular has been shown to be very effective with the youth population, because they don't quite yet have the disorder. They're more receptive to talking about and hearing about risk than being in a treatment program where they might not meet criteria, but they're placed in there because they get in trouble, right, in schools, and they get referred to treatment. So it's important that our programs and our systems have tools like SBIRT to triage risk more appropriately, particularly when we're working with adolescents who might not be in sick or disease states. Now what we're going to do is we're going to have Sherry come back up, and she's going to walk us through the steps of the brief intervention. But as she said earlier, the brief intervention comes after SBIRT, the S, which is the screening. You've all used screening. The intent is to talk with people, to have a conversation about their risk using the screening results. I'm going to let her take it up from here and walk you through the steps and hone in on some motivational interviewing stuff, and then give you some time to practice.
The brief intervention, so say we've already screened, so we've done the S of SBIRT. Now we're on the BI, and once we have an identified screening score and it's determined that we're doing some sort of intervention with this patient, our overall goal here is behavior change. We're conducting a kind of a brief risk reduction intervention with a patient. It may be risk reduction, or depending on what the screening tool shows, we may be moving more into trying to link them to more intensive services. But at the very least, what we're looking for is some sort of behavior change. That's our end goal. And in order to get some sort of behavior change, we're looking at how we raise awareness of the problem with the patient. So it really is, this is the kind of, when I said problem solution or problem motivational interviewing solution, this is really awareness of the problem that's determined through screening. This is doing some targeted counseling to increase motivation and get them interested in changing or getting them interested in some solutions. And then this is the kind of solution piece here. And we use our screening tool in this awareness raising with them because, again, we think of a screening tool as being an objective way to start to engage the client. So that rather than it coming from a, you know, you've mentioned some things and I'm worried you're drinking too much, or, you know, your behavior looks like this. It really is about something that's outside of the patient. It's more objective than that, is the hope. And then the targeted motivation is, here's some motivational interviewing, and then we move on to hopefully with making a plan for some behavior change. I mentioned before that all motivational interviewing platform underlies all brief interventions. So just to kind of get into the spirit of motivational interviewing, I'd first like you to think about your least favorite supervisor, your least favorite boss or professor that you've ever had, or supervisor. Everybody have one person in mind? Okay, I'll repeat this for the camera, but just give me like a holler out. Give me one quality that is the thing that made them really not very likable to you. If you can think of one quality. Yes?
Refusal to understand the normal procedures of the clinic.
Okay, so refusal, so not following the rules. Okay, not following rules. What else? Okay, so borderline. So they had their own, they had their own, say it again? Inconsistent and unreliable, not clear messaging, so it's really kind of not stable for people who are in there because they don't really know what they're going to get. Inconsistency. What else? Yes? Yes, so maybe not giving you feedback, but then some people who don't give feedback, but then when you do something eventually that they don't like, then it's really severe. Then they jump in when they could have been giving limited feedback along the way for corrective behavior. Right, so maybe it's opinionated, but also rigid, like this kind of inflexibility, not really understanding where you or other people are coming from and being kind of, it's black and white, not really understanding the gray, the human element of that. Okay, anybody else? Yes. Okay, so not being approachable. Yeah, it kind of makes it for an environment where people are uncomfortable, they kind of walk on eggshells, they're not really sure what they can approach them with or what not. Okay. When you think of all of these qualities or characteristics, we really think of them as they're really kind of communication blockers, you know, because they limit the amount of communication or dialogue. We think of them as blockers. And we think that they kind of are roadblocks to communication. When we think of how brief interventions, like all of your counseling gets delivered, hopefully, we try to think of these effective motivators versus ineffective motivators. And very often the things that you are talking about, they're communication roadblocks and they're also ineffective motivators. People who are inconsistent or too rigid or have borderline personality disorders don't really follow the rules. They're not really clear with communication and giving you feedback. Those aren't things that are very motivating for you. They aren't motivating in terms of your career or in terms of you furthering whatever it is that you're doing in your work environment, or maybe it was a school environment. Things like being patronizing or very ignorant, really not understanding, or maybe even arrogant or judgmental. These are all things that during a brief intervention, that we really want to stay away from. We want to think of our delivery in this effective motivator way, sort of the nurturing, the consistency, the flexibility, the being more empathic, kind of understanding the grays, not just seeing things in black and white, good listening skills, actually hearing what you're saying, this kind of supportive and non-judgmental. These are all what we call effective motivators, and it's kind of the style or approach that we want to have during a brief intervention. You'll sometimes see, you watched a brief intervention today that was had 12, 13 minutes, I think. Sometimes 17 minutes. Sometimes people are trained to do brief interventions in hospital settings in like 5 or 6 minutes, and so they really kind of cut to the chase. They can be a little more directive, but if it's not done in a style that is somehow motivating to the patient, we've already lost them. And the idea in a brief intervention is that we have such limited time with them that we really can't afford to lose them. So even though we're directive, we have to kind of keep these, or more directive than maybe we are during kind of ongoing clinical sessions with them. We have to keep these in mind because we still want to keep them engaged in the process, okay? So this underlying spirit of kind of partnership and autonomy and being accepting and non-judgmental and being empathic and having compassion, being supportive and non-authoritative. We also sometimes think of skills that we get better at in brief interventions, though, is having a level of, I don't want to say direction, but there is a level at which we're trying to be a little evocative. You know, there is a bit of a evoking or calling forth, because we're not just there to, you know, support them and say good job. We really have to try to be a little evoking with them, be a little evocative. We're trying to get them to think about some things, but we want to do it in a way that we kind of, it's done in a gentle enough way that they're able to kind of think about things without feeling like they can't stay in the process with you, okay? I don't know if that makes sense, but in kind of MI training, as all of you have had, we do talk about being a little evocative and how and when is the right place for that during a brief intervention. So again, these are communication styles that when people are often too directive or dismissive, or we've come across these communication roadblocks, the outcome for us on the receiving end, if it was our teacher or our supervisor or a coach of some sort, all of those communication blockers make us feel kind of defensive or angry. We feel trapped. We feel frustrated, maybe annoyed, maybe uncomfortable, or just disengaged in the process, maybe a little fearful. Those are things that we want to ensure that we don't want our clients to leave feeling any of this during the process of a brief intervention. So it is this delicate balance of communication. Now, the 4 steps of a brief intervention, which are on this card, and essentially, I'm going to walk through them quickly because we've already kind of gone through these steps when we did our kind of, Scott, right? When I did my kind of brief intervention with Scott, I raised a subject with him about his blood pressure. I gave him feedback that I had some concerns and that this was the score of his blood pressure and it was high. And I maybe even added a little education about what blood pressure measures and when it is not stable, what kind of consequences it can lead to. These are kind of the things that happen during these first 2 steps of a brief intervention. We actually gave you bulleted text that you can even say just to kind of get you started, like stems, like, is it okay if we review your screening results? I assure you that everything you say today will remain confidential unless I feel you pose a danger to yourself or others. You know, according to the screening tool, you scored a blank, which puts you within this category. I'm concerned. So we kind of give you things to start with so that as you're practicing, you have something like really concrete to rely on and just to say until you get comfortable delivering this in the way that best fits you and your personality and your speed and your patient population. We give you a couple stems to use. And the same goes for, there's a sheet in here that essentially does the same thing. The first step, raise the subject. Build rapport, ask permission, discuss limits of confidentiality. Step 2, provide feedback. Give them a risk score and tell them what this means, what this risk score means. I sometimes like to use the example of my dog, when I took my dog to the vet and they did some blood work, and they said, well, your dog's, whatever indicator it was, your dog, it's, you know, 27,000, blah, blah, blah. And my thought was, oh my God, my dog's gonna die. 27,000 sounds like high, right? And then they gave me the range. The range is between 24 and 30. And I was like, oh wait, my dog's gonna live. He's right where he's supposed to be. But I didn't understand what the scalability of this was. What's the scale? What does it mean? So these scores, sometimes when it's appropriate, and a lot of this is your clinical judgment, when it's appropriate, you educate the patient about what this means in the process so they understand. Just like your doctor may say, this is your red blood cell count, this number means you may be anemic, this number may mean this. It kind of invites you into the process of understanding something more about your health, and that is what happens during kind of this step 2 process.
So what I want to briefly point out in your packet is these motivational interviewing principles. Curtis and William went over ORS, but we do have the step-by-step strategies. This isn't an MI training, you know, we go into more depth. So we're just kind of surfacing the ground here. You all know MI, right? Show of hands, who does? Okay, good. So MI strategies and ORS, it has the description there, open-ended questions, personal affirmations, listen and engage in reflections, and provide summaries. And it has some script too. Like if you can use these with your students or during supervision. You know, it's a tool for you to use this. And then there's the principles that we're gonna go over too when you're doing a brief intervention during steps 3 and 4, which are these 4 on the back side: express empathy, roll with resistance, explore discrepancies, and support self-efficacy, with some examples and some scripts. And so depending on your client and in the situation, you may have to pull in some of these things. You might not use them all the time, right?
Great, thank you. So the basic 4 steps of the brief intervention, as I said, raise the subject, provide feedback, enhance motivation, negotiate a plan. Reminders that it's always good to ask permission. You scored a blank on this. I'd like to talk with you more about that. Is it okay if we have a conversation about this? It's always inherently respectful to ask for permission. Ensuring their confidentiality and also normalizing the screening tests can always be helpful. That's really about screening for alcohol, drug use, tobacco use, or any other type of risk is something that we do with all of our patients. So the most important thing about screening in a real kind of when SBIRT fully gets implemented, it is about everybody gets screened. It's not about, oh, wow, this person looks like they really drink, let's just screen them. It's universal screening, so anybody who walks in the door gets it. okay? And reaffirming that with them so that they don't feel like they've been singled out or not special. Most people now, I think, are getting pretty used to being asked from their doctor, do you smoke tobacco? Do you drink alcohol? And, do you use recreational drugs? Some drug use questions less so. But screening has become more and more normalized, and so that's good. The second step of providing feedback, which we went over with you, the one thing I would say that's in the process of giving feedback that's important is if you can personalize it to them. So when I did a brief intervention with Scott, I said a high blood pressure can be associated with these various medical issues, and as your provider, I have some concerns. The feedback I just gave Scott was not very personalized. I told him that that's the type of consequences associated very generally, which can be helpful. But if we have the information to take it to the next level down where we say, and you came in here today because you've been feeling dizzy and you also mentioned, that you had been nauseous or something like this. And so I try to bring it back to you personally and your health. So it's if we can go the next layer, and particularly with patients or clients who come in and they've been feeling depressed, and we see from a screening tool or that they're there actually because they're depressed or they're anxious or they've been having some family issues, whatever it might be, the reason they're sitting in front of you. If we can make it kind of general, but then go right also down to, one of the reasons that you told the nurse why you're here today is because you've really been having a lot of trouble sleeping. And what I want to do is talk about, you want to try to get that connection because this is an awareness raising opportunity. If they leave with this idea that there's a link between the behavior that they're engaging in and how it's personally affecting them. That's the goal of this step. So whether it's your mom brought you in today because you've been getting in some trouble at school. So we might start out with the general kind of feedback and we try to move into making it personal for them. And then exploring these connections. Now, these steps right here, the enhancing motivation is it's really kind of the meat of a brief intervention because if we don't spend time here, the likelihood that they'll want to engage in behavior change gets less. So spending a little time here is important, but it's also the hardest place to spend time because not all of our work environments allow a lot of time to be spent here. Sometimes you don't have very much time. If you're in intake or if you're in a hospital setting, you maybe only have a few minutes with the patient. So there are a couple of strategies. Our goal during this kind of problem, counseling, solution, during this middle piece, our goal is to try to use one or two tools to get any type of change talk going or to get awareness raising where the client can maybe have that aha moment. So a couple of the tools that are used a lot in motivational interviewing to get people talking or thinking about their use and the connections between their use and some consequences are what we call a decisional balance and a readiness ruler. And I'm going to just spend a couple minutes on it. On here, I'm going to go over the decisional balance and readiness ruler with you, but we actually have a readiness ruler for you here and kind of a decisional balance here. So we kind of included the tools on this card for you to kind of get as reminders to you. A decisional balance is often what you think about when you think about a pros and cons list. So what are the good and not so good things about using? The important thing about a decisional balance, we tend to actually heavier focus in one area when we do this. And so I want to talk about the complete decisional balance because in motivational interviewing, it's also really important that we use all four of the quadrants rather than just two. But if I were to ask you, what is a substance that one of your patients is using right now? Give me an example of a substance they might be using or abusing. Marijuana, okay. So marijuana, let's tell me what are the pros, what do they say are the good things about using marijuana? What do they like? They relax? Okay, it helps them get hungry, maybe they need to eat. Maybe it helps them sleep, okay. They use it to relax, stress is high, it helps them chill out. Social, they use it with friends. Maybe they feel light, social when they use it. What do they say are some of the not so good things about using? It's starting to cost, maybe it's breaking their bank, maybe it's expensive. Maybe they start to feel anxious without it. So they're noticing if they don't have it, maybe they're irritable, a little agitated. Good and not so good. That's a typical pros and cons. Important to go over with patients. They probably already know the things that aren't working for them, and so inviting them to talk about the things that are working for them is good. In motivational interviewing, though, they will often say, depending on what the patient's drug of choice is, and depending how you should use your good clinical judgment about weighing the importance of this, because having patients, for example, yeah, I use meth. Oh, it's great. Oh my gosh, when I'm on meth, I just feel so wonderful, and I connect with my friends. The sex is better. I get a lot done. They can start to romanticize, and our goal here is not to have them ruminate and stew over how fabulous their drug of choice is, okay? We also know that when people, if they do have a real substance use disorder, people who spend time up there, it can be really triggering for them. So our goal is not to kind of let them romanticize their drug of choice. The goal is just for us to kind of validate to them, like, we understand that there's something that's benefiting you in this dynamic out of this. And so if you have a patient that you have some concerns about doing that with, you may say, like, what's your name? David. David, a lot of people, we say the pros. David, I know a lot of people like to use heroin because it helps them relax. They feel like they can escape their problems, and they like to use with friends. But sometimes they also experience some consequences. Can you tell me a little bit about the consequences? So you say the positives, so at least they know that there are positives. Depending on the patient, you may go that route. It's really sort of your call. In motivational interviewing, they will say, we failed to spend important time here, which is where we should be spending time. And in particular, we should be trying to get them to talk about this, okay? Now, the reasons to change are often tied with the cons. So the not so good things are, I don't feel that motivated, I'm wasting a lot of money, I've gotten in trouble at home because my parents are upset. So the reasons to change are they'll often verbalize those things as why they also want to change. But having them engage in what we call change talk, where they're saying, well, my grades have been slipping and I don't want that. Like, we want it to come out of their mouth, whereas it may not always come out of their mouth up here. So we really want them, the other thing about MI is we want them to be future oriented. Okay, we want them to be thinking about the benefits of what's next, okay? And so getting them to spend some time down here is important. Again, these two tools are all about kind of trying to get them engaged in change talk. So this is a tool that can be used sort of sequentially with a decisional balance, or sometimes people, if they don't have a lot of time, they may just use this, or they may just use the decisional balance. But the thing I like about a readiness ruler is it does kind of try to get you to the next step of, okay, what are we going to do about it? Are you even considering change? And if so, what kind of change are you considering? So a readiness ruler, if our goal is change talk, a readiness ruler is a little bit of a trick to get them to engage in change talk and to verbalize some consequences, potentially. So what's your name? Jens. Okay, how do you spell that? J-E-N-S-S. Oh, what a cute name. I love it. So Jens is, let's see, she's young, she's cute, she has a good job. I don't know about and she loves her life. Well, except she has had a couple, she actually has been having, say, some trouble sleeping. Let's go with sleep. Do you want to have sleep issues, or do you want to be like a little flat and depressed? Which one do you want to be? I'll let you choose. Okay, so Jens is like a little bit depressed. She goes under a primary care physician. They do some standard mental health screening, and they screen her as having, like she screens positive for kind of feeling a little flat, and the doctor brings it up with her. They do talk about some things related to drinking, because she discloses, well, sometimes I, go out with friends, and so she does occasionally go out with friends. She likes happy hours. She likes margaritas in particular. She got pulled over once. She was worried she was going to get a DUI, but she didn't. She also got written up because she came in late a few times on Friday mornings, because Thursday happy hour has better prices, so she goes out Thursday night with her friends. In the process of kind of exploring issues related to her drinking, someone may ask you on a scale, a provider may ask you on a scale of 1 to 10, how interested or ready are you to make any changes to your drinking? Okay? You, as the patient, then put a number on this. Like, where are you at with this? And you give me a number. 4. Okay, so a 4. Now, patients who tell you 9 or 10 that they're extremely ready, usually there's a reason, like something happened, like they are not people who need to be totally motivated. They're already talking change talk on their own. They're like, I got arrested, my parents are gonna kick me out if it happens again, I broke the bank, I have no money. Like, they're change talking all the time. People who are down here are completely in pre-contemplation. There's 0 issues. For people, 0 issues that they've identified personally. People who score anywhere kind of in this area, there is something there, but maybe they haven't verbalized it a lot. And so what we often do in using a readiness ruler is we'll ask you, so Jens, you said on a scale of 1 to 10 like a 4, which indicates that you have some interest in changing. So why did you give it a 4? And then our next follow-up question is, why did you give it a 4 and not a lower number? So if we phrased it the incorrect way, if we said, Jens, why did you give it a 4 and not a 10? Now everything out of Jens's mouth is, well, I'm not a 10. A 10 is like someone who totally needs to change. I'm not that bad. I'm just kind of, not sure. We never want to ask why not a higher number. We want to do the opposite. We want to minimize the problem so she maximizes the problem. So we say, well, why did you give it a 4 and not say a 0 or a 1? And then everything now out of her mouth is, well, a 0 or a 1 is probably someone who doesn't have any issues, and I did get pulled over. So she's starting to verbalize some consequences out loud. I don't know if does that make sense? So we almost take the position as the provider of minimizing it for her so that then she kind of has to amplify a little bit and start engaging what we call change talk. Once we kind of have gone through that process, the last step is, is the patient interested in doing anything at all? Once you've kind of talked this through, we've had this discussion. What are your thoughts about this? You mentioned, you're at a 4. What would you be willing, or what are you interested in possibly changing? There are a whole range of things that patients will say. Everything from, I'm really not interested, I don't think it's a problem, all the way to maybe, help me get in treatment, which is the rare extreme end. But in the middle there's a lot of options that they may come up with for you about what they're interested in changing. And this is this behavior change. We've planted a seed, we're gonna follow up with them and see, but there's the smallest level of commitment that we're trying to get out of them to try something, try anything. And even if a patient says, I like to use an example of when patients say that they don't want to do anything or they're not really sure, they don't really think that's a problem. And not all is lost, because for you as the provider, if they're willing to do one thing, which is, over the next month, would you be willing just to kind of take a look at where this is at and just kind of where your drinking or drug use is at? If you can get a follow-up 2 weeks, 3 weeks, 4 weeks with them to kind of see, because when we ask patients just to look at their behavior, even after a brief intervention, most people are not very aware of their patterns. And so if I asked you guys all right now, raise your hand if you know the number of days in the last 30 days, the number of days, either exactly or pretty close, that you've eaten salad in the last 30 days. Salad. How many days in the last 30 have you eaten salad? Do you have a pretty good idea? Okay, raise your hand if you have a pretty good idea. Okay. Yeah, how many? 14 or 15. Boy, he's good. So about every other day. 21. How do you know it's 21? Right, so people who eat it very regularly, or anybody who knows because they don't eat salad ever here? There are some people who say, I know exactly it's 0, or I know exactly it's 1 because I never eat it. Most people are not that aware, and if they are, it's because they're pretty regular eaters. They know that I eat it every day during the week when I'm working. I eat it every other day. Most people are not that savvy unless they do something very regularly or never. And so for those of us who kind of are, in the middle of, people aren't hyper aware. So when you ask patients over the next month, can you take a look and just start to kind of track your drinking or your drug use, and so we can check back. That's not asking them to change anything. It's just asking them to be aware. Because when they report back, having someone become hyper aware of a behavior they're engaging in, they may not do it, but the next time they pick up a drink or they use drugs, there was a tiny, tiny little seed because you've burrowed in there saying be aware of it. So at the very least, they're actually thinking about what you said. So even if they say no change, it's okay. One other thing about brief interventions is take pressure off yourself, because your job in a brief intervention is not to get people to wholesale change. If you got, remember, the tiniest movement, if you've gotten a pre-contemplator to contemplate for a minute, it's a win. If you've gotten a contemplator to start to take action, that's a win. If you've gotten someone who's really kind of in preparation, has been thinking about it, and you've actually gotten them to take a first step to making change, that's a win, okay?
So before you practice, the one thing that I will add, and it just speaks to what Sherry was talking about, is the small steps are wins. And so the other thing that usually goes with the brief intervention as you're doing it is to be mindful of the stage of change, right? So where the individual is at, and this is just happening throughout. So you can't just assume you're gonna finish the brief intervention and they're gonna be in action mode. Right? And so this is like a disservice to ourselves, where we're like, we went through the steps and they should all be there. That's usually not the case. And so just really being mindful of this from where they're at on this continuum, if you will, of change and what progress looks like. And sometimes it's simply thinking about it. With adolescents in particular, be okay with them being in denial or pre-contemplative, right? Because most of them, when you say, let's talk about your alcohol and drug use, they're going to say, I don't have a drug problem. And adults as well. But even if they do have a drug problem, there's biased perceptions of risk with adolescents in particular. So with adolescents, we need to be mindful of their culture, right? And the generational norms that are going on right now. And you guys brought up marijuana being like a common or problematic issue. Alcohol, marijuana, tobacco, these are all substances that are culturally accepted, culturally ingrained in film, in media, in entertainment, in music, in our neighborhoods, and they're widely available and accessible. So when you start to talk about alcohol and drugs being problems, we run into a boatload of issues, right? And the other thing comes with the shame and the stigma and the fear and embarrassment that adds another layer. So just being mindful of that. It's different to talk about alcohol or drugs than to talk about eating 5 cheeseburgers, right? Diet and alcohol and drugs, there's some nuances and some differences. So it's to keep in mind that, and to keep in mind that it's culturally and socially acceptable. And adolescents, like you saw Brady, they have biased perceptions of risk, right? And so I did a lot of work with adolescents. And so this has come out time and time again because the substances they're using, let's do 2 common substances that they use, prescription drugs and marijuana. Why do you think their perceptions of risk are biased? Meaning they don't think they're risky. All their friends are doing it. Why else? It's prescribed by a doctor. Bingo. That's one of the driving issues with adolescents and young people, and probably some adults, where it's a medicine.
It doesn't matter that the doctor works on Venice with a flowered shirt, and he guarantees you for $40 you'll get a prescription, even if you have a hangnail.
The Green Doctor. Have you seen these on Venice Boulevard? Yeah. So it's a medicine, it's a plant. The thing with e-vapes and cigarettes, same kind of thing. They're natural, they shouldn't be harmful, it's prescribed, it's medicinal, right? This is the culture, and you need to be mindful of that when you're starting to talk about the risk and screening them around standards. With alcohol, like Sherry said, there's a lot of research that we have to use and some objective measures. But once you start opening up the work can with alcohol, marijuana, prescription drugs, and these other tobacco, you're going to get a lot more resistance, particularly with the youth culture. And this is research that shows that NIDA, the National Institute of Drug Abuse, this is 12th graders, and this is the correlation between perceived risk, the extent to which they have risk perceptions and they think it's harmful to use marijuana, and their use, their correlation between the two, the attitude and the behavior. And you see that there's an inverse correlation, right? What does that mean? It means when they perceive marijuana to be risky, their use is low. When they perceive marijuana to be not risky, their use is high, right? So there's an inverse correlation. So it's important to really understand this with youth, and half of the room is working with youth, and also with adults, right? When you're the culture and the norms out there around medical marijuana, and oh, it's safe and it shouldn't be harmful or hurtful, or I'm using it because of my pain or opioids or prescriptions, you know, just know that that goes on, and it's very common responses, and how you need to prepare yourselves with really understanding the effects and the nuances and acknowledging this, but then being able to move on. And this is something that I think is important with marijuana. And, you know, we talked about the developing brain, and well, marijuana is the safest drug on the planet. You know, it has no effects at all, and you can use it and not be harmed. And, you know, with research, particularly with the brain research that's going on, a study that got put out by the director of NIDA, I think eloquently presented this research that really is eye-opening, where it shows that there's a lot of marijuana or cannabinoids bind THC ingredient products, products and ingredients bind with a variety of different brain regions, right? Not just the prefrontal cortex, but it affects the whole brain. And for young people in particular to think, well, it doesn't even affect, you can't have any health effects related to it. This is a very strong information to include. So here, integrate content-specific information about marijuana research and the adverse neurological and effects during screening assessment, I think is important to have with you, because you're going to run into those biased perceptions of risk. And here's the study. We can send it out to you by NIDA, Nora Volkoff, and it got published, and it shows the detrimental effects of short-term use of marijuana, and the effect is stronger. It's associated with initial marijuana use early in adolescence. So altered brain development, interfering with driving skills and risk for injuries, increasing your risk of sexually transmitted diseases due to high-risk sexual behaviors, dropping out of school and poor performance there, educationally lower IQ and other cognitive impairment, paranoia and psychosis in high doses, and increased risk for chronic psychosis like mimics schizophrenia later on in life. This is something that we've shown adolescents too that's kind of eye-opening about the IQ. And there's 8 IQ point drop among early and heavy users. So adolescents who start earlier is important to point out in terms of the vulnerability with these effects.
So for the role play, what I want you to do is you can hopefully switch roles with your partner. You have an instrument with a score now, right? Everybody has an instrument with a score. And you are going to be giving feedback. You're going to be walking through a brief intervention based on that score. So here is the one that says brief intervention steps for SBIRT. This can kind of help you walk through. There's text that you can use. You guys are clinicians and providers, so of course if there's earlier stuff that you like to do in terms of when you first meet a patient, whatever you want to do is good. These are just kind of the brief steps to kind of guide you and help you get through a brief intervention. If you need any reminders of the MI platform by which this is delivered, the kind of empathy, exploring discrepancy, but I think in some ways walking through it simply the first time or two is actually a good thing. And if you are the patient, don't be the meanest patient you've ever role played, only because it's helpful to help out your provider, your pretend provider here, in getting them through the steps and getting sort of comfortable, because of all the things that you learned in your mental health training, this is probably the simplest, most concrete, and easiest. It's pretty much, it does have formulaic sections that can be flexible in each one. So walk through it an easy time and see how it goes, and then maybe you'll, practice it more with other providers in your workplace that you can get comfortable doing it and then get comfortable supervising it. We gave you some role plays if you want to use them. We have 3 case studies, and they range from an adolescent who's, they kind of range from severe to moderate to low risk. And so you are welcome to review that case study, or if you have a patient in mind that you feel pretty intimately familiar with, you could role play that as well, okay? I want some feedback from the clinicians. I want to hear from a couple of the providers. Easy, hard, tell me how it went. What was it like here?
I think it was pretty straightforward. I found myself kind of trying to weigh the balance of providing information from around psychoeducation and how much of that to give versus just kind of to roll with the client and what they were offering.
How about the decisional balance or the decisional balance or readiness ruler? Did you use one or both? Both. How about anything, other clinicians? Easy, challenging, pretty straightforward. Were you a clinician? Yeah. What'd you think?
Yeah, I thought it was pretty easy. The model's really clear. The steps were laid out. Obviously, I had to keep looking down at them. But
Okay.
But I think it was pretty easy to use.
Easy enough, where you could see yourself kind of using those basic steps, but layering on you within there as a.
And they flowed naturally,
from
step to step. So.
Okay, good, easy enough. Any other clinicians over here? I want to hear from a clinician.
Yeah, I think I got hung up a little bit because my steps overlapped each other a little bit.
Okay.
And I was trying to figure out whether or not I needed to go back and kind of do more on one step, or since I was already seating with one foot in the next step, I should just go with that. So,
right.
But I thought that when I kind of clarified, I looked down at the card and saw, okay, and realized where I was. The card gave great cues. I think with 1 or 2 times just kind of practicing it, I think it would be really easy to implement.
Okay. And I think you make a good point is thinking of these, we've kind of artificially chopped these into discrete steps for educational purposes, but in the flow of things, if you flowed and realized you wanted to flow back and then flow back forward, I think that's just okay. I think that will also work. Anybody feel like, I guess before I hand over Rachel, one last thing from patients. Can I hear from a patient any experience how they thought it went, anything that they got out of it or didn't?
Yeah, it was actually very comfortable, and I actually like being able to talk about my experience and have somebody listen to me, even though I thought maybe they wouldn't agree necessarily with my position.
Okay. One of the biggest issues about, as I said before, about doing brief interventions is that it might be a job change, or it might in your site be something that's new. Even though none of these components are anything that are new to you, the packaging of them or the ordering of them or the implementation into your workplace setting may be new, and how it gets reimbursed and paid for and so on and so forth. Thinking through your target population, the appropriate screening tool, whether or not the provider could easily score it and use it in an objective way in an intervention with the client, and how this gets sustained beyond particular providers. Because in your experience in the back, this has been going on at your hospital for many years. Sustainability is key. What's your name?
Phil Snyder.
Phil. If Phil leaves his hospital, even though he probably won't because he's been there over 30 years, but if Phil left tomorrow, this practice would still continue. It's not contingent upon Phil being the champion. It sometimes takes a champion to start it, but when it becomes a sustainable feature and alcohol and drug use gets screened and intervened like any other practice, that's considered a win in the world of SBIRT, and that's when it's most effective. So thinking through these implementation barriers, and for you thinking through how you can support clinicians and providers to do this practice, to continue to see value in this practice, is important. The referral to treatment piece is important to think through, especially considering the faith integration piece that we're talking about. We want to do one last brief overview of the RT.
In step 4 of the brief intervention, usually if there's high risk, or if you feel clinically that your client can really benefit from a further assessment, either in your agency or in another agency within the community, you would then make the referral to treatment, right? The referral for further assessment. The RT is used, but it might be referral for linkage, right? So it might be an RL, right? An SBIL. So it could be something where you really feel you need to make an additional referral. And we really wanted to just spend a brief moment talking about the specialty system of care for substance use disorders. Some of you might be very familiar with this, so it might be overview. Some of you might not be familiar at all, or with little information. So part of the SBIRT training within mental health, healthcare settings is talking about the system of care, or what we call a continuum of care within specialty addiction, within a specialty addiction system. And it ranges, and this isn't supposed to be linear. However, there is, depending on severity of the assessment. So when you refer them to a specialty side of things, usually you're going to want to refer them to the lowest hanging fruit. If you don't know anything about substance use, particularly if you're not real trained on, are they going to need detox versus a residential rehab place that they're going to have to live in versus an outpatient setting, the best practice is to get them to an outpatient setting in their community. And so at that place, they would get a full assessment. And the assessment should be the ASAM assessment. And it's a tool it's multidimensional and asks a variety of questions about history and functioning and impairment. And then it would then trigger if they need more intensive level of outpatient care, more intensity of services, maybe a residential rehabilitative system. They might need medication-assisted treatment or detox. Detox doesn't have therapeutic clinical services. Detoxification is usually for somebody who needs to be managed medically and overseen so that they don't go into medical seizures or have issues that are severe when they're coming off of substance, usually alcohol or heroin or opioids, where their body is physically going to go through things that would put them at risk medically, that they need to be supervised. And once they go through the detoxification process, and depending on setting, they would then integrate them into these more clinical treatment services, that individual therapy and group therapy. I want to point out, so that's the system of care. Medication-assisted treatment now is being pushed for opioid and alcohol, and we have a lot of effectiveness studies around things like buprenorphine, and methadone's been around for a long time. Naltrexone, naloxone, Vivitrol, just a variety of different medications that are becoming more and more available to help with the craving and to help medically manage as they move in or transition down between levels of care and into recovery. So aftercare is a new service that's been available and added to benefit packages, most benefit packages, but for the longest time, this aftercare was not billable, right, to agencies within a specialty system of care. And aftercare is simply the referral to Narcotics Anonymous or Alcoholics Anonymous, NA. These are the 12-step model. And it's led by individuals, grassroots in the community that are usually recovering, right? So there's no clinicians in NA or AA 12-step groups. There's no medical nurses or medical doctors or social workers, right? And so this model, although that's important, support groups, but what the field is pushing is for more, for aftercare that has built-in professional skills or built-in models that they are receiving, like counseling, some type of recovery support to monitor relapse symptoms, if you will, like craving, and check in if they're meeting their recovery goals. And if they're not, then they would then help them come back into the system, not just completely out in a support group that's talking about sobriety, right? So it's support group plus this structured aftercare kind of model that promotes wellness, that promotes exercise, that promotes changed diet, that promotes medically monitored monitored self-management of behaviors. And so that's the models that the field is really taking ownership of and trying to promote. The other thing that is important to know when you're doing a referral to treatment is to have a list of referrals handy, right? That have resources that you know about the system, right? You have detoxification. You know what's in your service planning area. You know, you've made some connections. You've called. You said, I'm a mental health provider. Can I, if I have substance abuse clients, what kind of services will I expect them to get there? Make these connections ahead of time so that you can know and be able to explain to your client about versus here, take this number and go call them. They provide some sort of service that might help you, right? So get to know the services in your area or where your clients live around the area with outpatient residential detox. Also they might need hospitals. Know that 12-step groups, know support groups, but not just the support groups, right? The first thing that comes to mind, and if you think about substance use and you think about recovery, it's like Celebrate Recovery or the 12-step. That shouldn't be the referral place. It shouldn't be go online and look at a 1-800, Gambling's Anonymous or Alcoholics Anonymous. No, that's a place, like you just learned, where they are in recovery. They've already gotten the tools and received the services that they need to then work on their sobriety. So that's a step that should be integrated with the system of care or post system of care. We talked about integrating faith and spirituality, and maybe it is these non-secular based programs and services that are also recommended with the and, not or, right? So programs that you want them to be exposed to evidence-based models and strategies to really help bring healing, give them skills that they might need to work on their cognitive behavioral issues, but also somewhere where they feel comfortable and they can infuse their cultural views and spirituality and faith, like churches or other faith-based programs in their community. They might have housing issues, so sobriety, sober living houses or halfway houses. So this is just good to have and know, right? So maybe start building this for your agency, so that when your students come or interns come and you are doing SBIRT and screening, and should that high need come into play, you don't provide those services at your agency, but you want to get them to somewhere that does and can provide that. This is also important to know. Every county health department has services for substance use disorders, works within that specialty system of care. Many of you are probably familiar with the Department of Mental Health, right? So getting familiar with the agency that provides substance use services in LA County, it's SAPC, the Substance Abuse Prevention Control. You can go to their website and they have a listing of all of their detox, outpatient, residential, medication-assisted treatment services, so you can start there. So this is just where do you start, right? Start at the local level, at the local health department level. San Bernardino County's here, Orange County, Riverside, and Fresno. These are lines you can call, say, well, I'm a mental health provider, I'm trying to develop a network of referral. Do you have resources? Do you have forms you use? These types of things. So get familiar with that, and they list both programs for adolescents, programs for adults. And then SAMHSA is also a good resource. If you go to this website by itself and you have it on your desktop and I would suggest you save it. They have the SAMHSA treatment locator. You can visit this site and bookmark it. And right here it says enter a starting location. If you put in an address, a zip code, a city, you'll get a list of facilities of detox, outpatient, residential, all of those similar services that you would get at the county health department. But what happens is if you have that client there and you say, well, what neighborhood do you live in? What city do you live in? What's your zip code? You can by-step the county and you can get them, say, well, here's a listing. Can I print it out for you? And you can go to the SAMHSA website, put in the zip code or just city, and then a list comes out that you can print and give to them or call or make referrals. So this is a good steps to do or to take as you're engaging in that referral to treatment with your client. And then the warm handoff, remember it's within a scope of practice. And as Sherry talked about, it might not be you, but you might hand them to someone that can do that, or make sure they're doing it within your agency. Because this is the part of SBIRT, I got to tell you, that has fallen through the cracks, right? Screening is done, the brief intervention and the steps are done, but the referral is the piece that has been shady, if you will, because either on the part of the provider, not having the knowledge of the information of the larger network and system, and lacking of these memorandums of understanding or integration efforts generally, and operating in silos. Who operates in silos in the county? Or on the part of the client, right, with them just not wanting to hear it or receive it. So being proactive, learning about the services prior and being prepared, having positive relationships with those agencies, and knowing what resources are available that they provide. Do they have free services? Do they offer parenting classes, all sorts of other anger management? What kind of resources that might be helpful for you if your client doesn't want to go there, that well, they have substance use, but they also have family services or anger management that you might not have. And then just know your church area, or consider ways to promote wellness in churches or with this community if this is new for you, right? Getting to know the faith community and building that. And also understanding how they view substance use, and so you can know when you deal with your clients, is the church that is up the street a safe community? Like, what do they preach at the pulpit? This type of thing that Curtis or William would say. So knowing these things. This is for you to have and use. I think the pocket card is really useful. All of your students are exposed to this. And so if you want these pocket cards, you can go ahead and email us at the end. Ashley is going to be handing out forms where you can put your email at the top. And if you want to just put a note saying would like resources sent over, or we can send you an email and get your address, because we can print these out for you and deliver them, or send them in the mail if you want to use these. So we can provide that to you. These forms are also available on our website. So I wanted to allude you to our website as we end here. Our website, again, as we talked about earlier, is sbirtfaithandspirituality.org. And we have more training there. So if you want to take this back to your agencies, or if you want to interact with it more, you can do so. What you would need to do is you would register, and then after you register, you can then come back and interact with it at your own pace. You can sign in, have your username. You can sign up for newsletters that we have. Our phone number and address are there. It has resources for, under the faculty and tab, once you sign up and get a username, you can download these tools yourself at your site. And they're under faculty staff, and it would be SBIRT Pocket Card, and then the fidelity checklist that we talked about that Curtis said he was going to share with you. You can download that here under role play materials called Brief Intervention, Observation, Evaluation. And you can start using this during supervision, should you plan or like to. So I wanted to call your attention to that. Here's all of our emails. We're going to send you these slides electronically. I apologize for the small print. What we ask you to do is you follow, there's housekeeping things. CEUs, there's a different evaluation form. I think it's the blue one for your CEUs, continuing education. And then for the SBIRT certificate that you'll get, you fully completed the one by California, part of this training, we need you to fill out that white form that Ashley's handing out. Sorry, it wasn't in your packets. And that's for SAMHSA. So SAMHSA has funded this project, and so they require of every training, it's called the GIPRA evaluation to note your satisfaction. It's brief. I know there's a lot of paperwork. And then if we get that, you will get your certificate of completion from the SBIRT training for that. And then for the blue one, you'll get your CEU certificate. So there's two different forms going on here. And part of SAMHSA, I should say, is they like follow-up. So they want to know if SBIRT, after participants are trained, typically the students, but also the preceptors and the supervisors, if it's going to then be practiced, if it's going to be taken to scale in your community, in your setting. So just when you provide your email there, please provide it. We will send you a 30-day follow-up. That's for SAMHSA. If you have time, I would really appreciate it if you filled that out. It's brief, a couple of questions, just to ask, to know if you're using it in your setting. Did you take it to your setting? If not, great, but state that. And I just want to thank you all for participating today. Thank you.